We heard a lot about radio guidance, but we want to see some images now. And Henk, I think, has some fluorescence for us to show.
So let me first give some disclosure. I think the studies we have been doing so far in the field wouldn't have been possible without the aid of industry and certainly the lab of Vijs and other people working in Leiden. What is interesting to see is that industry takes up also the interest in fluorescence-guided surgery, because that's what I want to address now at the moment. And if you compare, for example, the new XI system from Intuitive, it's 10 times more sensitive to ICG than the older was. And that is not necessarily a benefit, as Vijs already highlighted, but it is stressing the fact that we will getting better hardware, and I think we get it soon. So these are the fluorophores that have been extensively used in medical practice and studied also in the field of prostate cancer. And I'm going to address only one of them, SO456, in a later version of, in a later phase of my presentation. So the hardware was already mentioned. It's not only Intuitive, which is new XI camera, which is including near-infrared imaging, but other system handheld and laparoscopic systems are available even to more extensive spectra of light to be imaged. So we've seen the pictures of Vijs and why use near-infrared, and we haven't discussed that, but I would like the panel to think of that and maybe come up with a question: why are we using infrared imaging? Well, we think we use it because it's less visible in the wide spectrum of light, so it's not bothering the surgeon. And that's important if you're doing a sentinel node procedure, and it has been extensively discussed in prostate cancer. And I know there are pros and cons to the whole concept, but we used fluorescence guidance to do some clinical studies and see if the sentinel node principle in prostate cancer can help us forward and improve outcome. So I'm going to address some clinical data. This is the principle. It's the tracer that Vijs already showed you, non-covalently bound ICG. To this case, these studies, it's nanocolloid. It's now in Europe, at least, nanoscan. And technetium, it allows you to do a SPECT CT scan after intraprostatic injection, and intraoperatively, you can either use the gamma probe shown before or see it under near-infrared imaging. So we did two studies because there's basics that haven't been addressed. Where do you need to inject the tracer? And we did two relatively small randomized studies, about 60 patients in each arm. The first study compared intratumoral injection, as is shown in 2 injections here on the right, versus 4 injections distributed in the prostate. And basically what we found was that the percentage of patients with positive nodes was much higher if you injected the tracer intratumoral, but you missed some nodal metastases that were derived from non-index lesion tumors. So the conclusion of that study was you have to do both in order to do a proper sentinel node. And the second question, and this hasn't also been addressed, but Vijs was talking about the the non-covalently bound ICG to the nanocol and technetium, which is simultaneously injected in 1 injection or in 4 injections in this case in the patient. But you could also do it sequentially. So you can use nanocol bound to technetium, have a radioactive tracer, and then several hours later or several minutes even prior to surgery, you can inject free ICG. And we were interested in a randomized study comparing these 2 approaches. And the interesting thing that what we found was that if you use the right probe, which is bound ICG, you have a higher specificity. So the detection of nodal metastasis seems to be a little bit more specific if you use that hybrid tracer, as we call it. But if you use the combination with free ICG, you find more nodes and you find more positive nodes. So the number of positive nodes removed is higher if you use the ICG. So how does it look? Why do we do it? This is one example. This is the obturator nerve on the left side of the patient. This is the robot-assisted radical prostatectomy. And we go down onto the mesenteric fascia of the mesorectum. And then we look and we see that there is indeed a sentinel node very close to the rectum. We would normally not remove these nodes because they are below the mesorectal fascia. And we removed this case, the node specifically because it was detected. So what are the 2 applications I want to briefly address some clinical data from? The first indication is, can we detect lymph node metastasis more carefully if we go for sentinel node approach? So you can take out a lot of nodes, but then you remove a lot of nodes unnecessary, as Giorgio already correctly stated. So can sentinel node help there? Well, the positive predictive value of a sentinel node procedure is 94%, which is even much better than any PSMA PET imaging as we have available at the moment. If you do a nodal detection, you find 37% of cases, patients that still have nodal metastasis, even when their PSMA PET scan is negative. Another approach I'm going to show you some data on is the combination of the sentinel node procedure using fluorescence in the hybrid tracer to complement extended lymph node dissection, because 14% of the sentinel nodes are generally found outside the template of the extended lymph node dissection. Going back to the first question, the sentinel nodes to detect nodal metastasis. In this study, we compared our data from the National Cancer Institute to a peripheral hospital data that has the same radiotherapist. And the difference between the two groups, which are balanced, is that in one center, only prostate-only radiotherapy was given. In our center, we do a sentinel node when there is an increased risk of lymph node metastasis. And when these patients have a positive sentinel node, we do not only irradiate the prostate, but we also do radiotherapy to the whole pelvic area, adding ADT in both arms. So these are the radiological recurrence-free survival curves, which are a hazard ratio of 0.47. The approach using sentinel node was much better with respect to radiological progression, and this by avoiding unnecessary whole pelvic radiotherapy in 63% of patients. So the other approach, as I mentioned, is can sentinel node complement an extended lymph node dissection? For that, we did a retrospective analysis of all the patients that were included in sentinel node studies, combining it with extended lymph node dissection, 2 patients that had only an extended lymph node dissection. And here there is a small but significant benefit if you add sentinel nodes to the extended lymph node dissection. So interesting in that specific population that was recently studied by Matteo Droghetti was the fact that in particular patients with positive nodes outside the extended lymph node template detected by sentinel node had a clinical recurrence-free survival benefit. So what's happening next? We saw the PSMA data, and in particular, I think for nodal metastasis, the PRO-PSMA study, of which I show data here, was much better than any clinical imaging we had so far. So maybe PSMA can help us to detect not only by radioactivity, but also by fluorescence, the presence of nodal metastasis. So for that, we were so happy to collaborate with OnTarget Laboratory that provided this OTL78, which is a PSMA targeting DUPA-based ligand, and with the fluorophore in the near-infrared spectrum of light, SO456, as I mentioned earlier, and these are some data in mice. Now, the study we did was more of a dose-finding exercise. So these were the 3 doses that we explored in clinical practice in 18 patients, and we used the Vinci robotic system joined with the Medtronic-based Vision Sense imaging. And just to show an example, this is not on a lymph node, but this is the imaging we have. This is the regular Da Vinci system, and here on the bottom of the right side of the slide, you see the Vision Sense imaging. This is a tumor in the prostate. It appeared that it was very close to the edge of the prostate, so we decided to remove additional fat, which was covering the base of the seminal vesicles. And we sequentially imaged that as well. And then you can see the Vision Sense image again, suggesting at least that there is a positive surgical margin on that site. So certainly this is a small population, but we did look at lymph nodes as well. That's the topic of today. And we removed 80 lymph node packages in this small study, of which 7 had positive nodal metastasis. 4 of those, so 57% of these, we were able to detect intraoperatively. This is in vivo. And we have to say, and this was also claimed already by Giorgio, that nodal metastases smaller than 3 millimeters are very hard to detect, and we were not able to detect it. But if you use the same imaging system ex vivo, and you get 289 lymph nodes imaged in the pathology situation, and basically in the correct dose cohort where we downscaled the dose and waited 24 hours before surgery, we found all the nodal metastases being positive on fluorescent imaging. So the fluorescent signal is there. It's just that we need more accurate systems, I think, to pick the signal up. So where do we stand at the moment? And this is one of my last slides. I think it has been mentioned before. CT scan imaging may be only valuable if you have enlarged nodes. PSMA PET scan really added to that the much smaller nodes that we can detect. I think if we go for fluorescence tracers, it may have the benefits to be used intraoperatively, which is very interesting. And if you go for radio-based tracers, I think the size of the nodal metastases that you can detect is even smaller, although I put a question mark here because, as Giorgio said, even the smaller nodal metastases, radio tracers are missing. But what can be very helpful there if you add the sentinel node, because the sentinel node procedure is not sensitive to the size of the metastasis, and it's going to be able to detect even nodal metastases that are not even detectable by microscopy. Well, the rest of the slides, I think most of you have seen already in Thijs' presentation. I'm very much looking forward to the combined dual tracer, as Thijs already showed. It's going to be radioactive as well as fluorescent, and we hope to combine the benefits of both worlds into a clinical study at the end of the year. So what else are we doing? We're not only interested in tumor, we're also interested in reducing complications. And you can do that by better tracing which lymph nodes are relevant and which lymph nodes, when removed, only cause complications. And for that, we did some multicolor fluorescence imaging. This is in a PIC situation where the leg of the PIC was injected and the periurethral gland of the PIC. And there you can see where these tracks actually merge. And these are the first clinical data in which we have been doing it in men as well during prostatectomy, showing that, yes, indeed, if you use multicolor fluorophores, you're able to distinguish those lymph nodes from the leg from those lymph nodes from the prostate as well. Well, all this work we were not able to do all the work without the help of all these people. And I would thank everybody for participating, and I'm happy to address any questions if there are.
Thank you, Henk, and it was an extremely interesting presentation. We as surgeons basically want to see something. I mean, we like probes, it's true, but at the same time, they are difficult, not difficult to use, but they still require some, let's say, handling. And when you see something, you're happy to remove it and to tell your patient, okay, we basically removed all what we could see. So my question is, do you think the future is actually here, and how can we move forward? Which kind of studies do you need to prove the superiority of this approach and to replace an anatomically defined pelvic lymph node dissection?
Yeah, that's an excellent question, Giorgio. I think the first answer we need is whether lymph node dissection at all is impacting on patient survival. I think that's crucial. Then again, if we do those studies, and they are ongoing, and some of them, Tobias, you may help us there, the PREDICT study is almost finished, I think. It's difficult to get the right endpoints, but if you do not do the correct lymph node staging or lymph node dissection, you may not find the answer to help there. So I think if we're doing those studies, yes or no lymph node dissection in patients with prostate cancer, it would be very helpful, I think, to add these imaging modalities.
And do you think the role for this type of technology and technique is actually more evident when we talk about, and here I'm talking about systemic tracer administration, where we talk about recurrences, as Tobias Maurer showed in his pioneer work, or do you still believe that we can aim at maximizing local disease control with intraoperative imaging, even when the prostate is in place?
I think it's going to be both, It's going to be both, Georgia. What we find now, we also participate in a study. 50% of patients do not get a lymph node dissection, and many of them recur, and we use the imaging as proposed by Tobias. I'm not really sure that the fluorescence is going to be very helpful there, because the nodal metastases are in general very small, and you will not be able to detect them with fluorescence. But for the primary prostatectomy, for the surgical margin positivity prevention, I think fluorescence is going to be very helpful. I'm sure of that.
Yeah, that's Henk. You really nicely showed, the margin assessment during that one image. I think that's really, really good. Just to answer quickly your question, predict we scale up to over 3,000 patients now. Jonas Eckert is also in the discussion here, participating. So we still need to wait for that, for the lymph node value of lymph node dissection.